The broadcast is now starting. All attendees are in listen-only mode.
Hello everyone and welcome. Thank you for joining us for the NEHIC University program today on the proposed rule regarding certification standards. This is Kate Berry, CEO of National eHealth Collaborative, or NEHIC. NEHIC is a public-private partnership with a mission to advance nationwide health information exchange to improve health and health care, including. Today we are very pleased to welcome our distinguished speaker, Steve Posnack from ONC. I'll be introducing him in just a moment. Next slide, please. First, I'd like to briefly highlight a few of our upcoming NEHIC University programs. We offer a wide variety of education programs, including a Spotlight Learning Series on health information exchange, consumer engagement, and the Beacon communities, as well as careers in health IT, ONC initiatives, and trends in health IT innovation. Next slide, please. On Monday, April 2nd, coming up next week, NEHIC will host a webinar to announce the release of our new report entitled The Health Information Exchange Roadmap, The Landscape, and a Path Forward. Our panelists for the program on Monday will be Laura Adams, President and CEO of the Rhode Island Quality Institute, Tim Cromwell, Director of Standards Interoperability at the U.S. Department of Veterans Affairs, Tom Fritz, CEO of Inland Northwest Health Services, Jason Kunzman from the Beacon team at ONC, and Chris Muir from the state HIE team at ONC. All these individuals contributed to the HIE roadmap and are leaders in making HIE a reality, so please plan to join us on Monday. Next slide, please. Due to the huge demand for our program that we offered earlier this week on Meaningful Youth Stage 2, we're going to offer this program once again on Tuesday, April 3rd at 4 p.m. Eastern. Once again, we'll be joined by Rob Anthony from the Office of eHealth Standards and Services at CMS. Next slide, please. We'll have a series of webinars providing in-depth case studies on the Beacon communities. On Wednesday, April 11th, we'll have a program featuring the Western New York and Southeast Michigan Beacons. And on Thursday, May 24th, we'll have a program on the Utah and San Diego Beacon communities. Next slide, please. You can download and print the slides from today's program at the URL on the screen. Next slide, please. And during the program today, please submit your questions as they come to mind by entering them into the Q&A window at the right-hand side of your screen. And now we'll jump right into the program. So I'm really happy to introduce our speaker for today, Steve Posnack. Steve is the Director of the Federal Policy Division in the Office of Policy and Planning within ONC. Steve joined ONC in July 2005 and has worked on a number of different ONC programs. He served as project officer of the American Health Information Community Confidentiality, Privacy, and Security Workgroup. Steve currently serves as ONC's lead analyst for legislative and regulatory affairs and as a project officer for policy-related research projects and white papers, and contributes to ONC's privacy and security policy development. Steve has a bachelor's degree in computer science, a master's degree in security informatics, and a master's degree in health policy. We're really happy to have Steve with us today to talk about the proposed rule on certification standards. So after Steve's talk, we will open it up for Q&A. So once again, please do enter your questions as they come to mind. And Steve, you're up. I believe we're going to advance your slides for you.
Excellent. Thank you very much for the warm welcome and for the introduction. For those of you that are on the phone and that are on the webcast, the East Coast, I hope you're eating lunch while I'm presenting. For those of you that are on the West Coast, maybe you're eating breakfast, or at least having your coffee. So I am here to talk with you today about ONC's companion rule to CMS's proposed rule on Meaningful Youth Stage 2. I've done this, my shtick now a few times and been honing my presentation to really focus on some key points. For those of you that have caught any of the presentations that I gave at HIMSS, the HT Standards Committee, EHI, some other places, I'll be running through the same or very similar slide deck. May touch on a couple different points, but nonetheless, I feel as if for those of you that are new to the webinar and haven't heard my presentation before, I've been able to address comments as they come up or questions as they come up as I've gotten to other slides. So hold your thought, but if I don't seem to address it, then we will be able to get to it at the end. I'm hoping to do about 25, 30 minutes at a brisk pace, and then leave some time to hear some of your questions and have a little bit of dialogue. And as you may have heard if you caught Rob Anthony's presentation, we are in a proposed rule public comment period, and I can't really go into elaborate detail of rationale beyond what's in the preamble of the regulation that's in some cases excruciating detail. So in some cases I might refer folks to the preamble. In other cases I may just thank you for your comment. Please don't take any offense if I do that. So I am on the title slide just to ground folks that has a little the name of the presentation. Next slide, please. And I am without, unfortunately, WebEx connectivity or the Citrix connectivity for some reason. The HHS network seems to not like it today. So I'm flying blind, but I will be happy to answer those questions. And I will be giving out the slide number just to make sure, which seems to be on most slides at the bottom, to make sure that folks are tracking with me. So I am on slide 9, which says agenda. Just going to talk with you a little bit about our regulatory history, some new terminology and concepts in our proposed rule, and then go over a few major highlights. Next slide. So in our short period of time, having authority to issue regulations, which started in 2009 under the HITECH Act, ONC was codified in statute in the Public Health Service Act, and in some cases we were given authority to issue regulations. And so we've done that in a number of cases, the foremost being our standards and certification criteria regulation and the certification programs regulations that we've put out thus far. Next slide. So this is really the first element of our proposed rule that's a change for folks, and it's really a linguistic, semantic change that we did to help make our rule a little bit clearer going forward. We learned a lot of lessons last time, having been the first time that we issued a set of regulations, and we have really tried to do a better job making what is, for all intents and purposes, a technical rule more accessible to everyone, and for those of you that don't have the technical expertise that some of the entities, especially the EHR technology developers, have when they look at the certification criteria that we've adopted in terms of what they need to do to get certified. So as I go through my presentation today, I'm really going to talk about the fresh look that we took at a lot of our policies that were in our prior regulations, the flexibility that we've tried to sprinkle in and introduce in a number of different places, and then, as I just touched on, the clarity that we've tried to bring to some of our proposals, including using consistent terminology, trying to make them more understandable and more intuitive. But we are at a proposed rule, and as I've said in some of my other presentations, it's imperfect. And the purpose and why I'm out, giving all these presentations, which I'm happy to do, is to make sure that we touch as many people as possible so that we get as many comments as possible to make our rule better and as close to perfection as possible. So please keep that in mind, and I'll have my little public service announcement at the end about making public comments and what we're trying to do to make that easier for you. As I go through this, and as I touch on this slide about certification criteria additions, also keep in the forefront of your mind that the time period about which I'm talking has to do with what we want the world to look like in 2014 and what we want EHR technology to be able to accomplish and support and facilitate to support meaningful use for the EHR reporting periods that begin in 2014. So the one thing that we did to try and make our rule a little bit more intuitive
Steve,
And
Steve, excuse me, this is Kate. You're kind of fading in and out a little bit, so can you
okay.
just try to make sure you stay right in close to the phone so we can hear you clearly? You're clear, and then you go real soft.
All right, absolutely. Does this sound better?
Yeah, thanks.
Okay. I will talk right to the phone.
Very good.
So the one thing that we've done to try and make things clearer is that as we go through our regulatory process, we'll be in effect producing another set of certification criteria that will be applicable to the 2014 and beyond reporting periods and EHR certification. And so we had to find a way to distinguish between the certification criteria that we have today and the certification criteria that we're proposing to adopt for the future. And to do this, we determined that one thing that we wanted to do was to consolidate all of our certification criteria into one regulatory section. And so we picked, in the Code of Federal Regulations, Part 170, Section 314. Previously, we had our certification criteria spread out across 3 different sections, one that focused on general certification criteria that were applicable to both the ambulatory and inpatient setting, and then we had 2 specific sections, 304 and 306, that were applicable to the ambulatory and inpatient setting, respectively. So what we've done to try and make the rule clearer and make it easier for people to remember the addition of certification criteria that we're talking about, we now refer to all the certification criteria that are currently adopted in rule in our July 2010 final rule as the 2011 edition EHR technology certification criteria. And the certification criteria that we proposed that we will adopt in a final rule this summer, we're referring to as the 2014 edition EHR certification criteria. And it's important to kind of keep those 2 concepts in mind. I'm going to be using that vocabulary quite a bit in the rest of my slides. I also included here a very crude, rough, unscientific quantity of the number of certification criteria that are in both editions. Like you probably heard if you caught Rob Anthony's presentation with respect to meaningful use, we've done in some cases, we've split certification criteria to make it easier for EHR technology developers to get certified to specific components. In other cases, we've combined to make things more efficient. So there really isn't a 1-to-1 ratio between the 2011 edition, the 2014 edition, nor is there anything to read into that we've increased the number of certification criteria. But I didn't want folks to see that we didn't increase them by some exponential amount. All right, moving on. So the next 3 slides that I'm going to go through have to do with the categories of certification criteria that exist within the 2014 edition. So we have 3 categories of certification criteria: new certification criteria, revised certification criteria, and unchanged. And we've used that terminology and explained them in a little bit more detail in the preamble of the proposed rule. But largely, our hope is that they're pretty intuitive. New certification criteria, as the slide that I'm on today, are those that weren't in the 2011 edition, and we've proposed them for the first time and are expressing capabilities for which certification would be required that we didn't include in the 2011 edition. And these largely support the new objectives and measures that were proposed by CMS for Meaningful Use Stage 2. Next slide. So the revised certification criteria, as the name is supposed to connote, are certification criteria that exist in our 2011 edition that we revised for the 2014 edition in a variety of different ways. And that includes either expressing different functional capabilities, including different standards, references to different standards or implementation specifications, or in some cases constraining a particular vocabulary or code set to be different than what it was expressed in the 2011 edition. Next slide. The last category, as I noted earlier, has to do with the unchanged certification criteria, and these are the certification criteria that carry over between the 2011 edition into the 2014 edition certification criteria. And so it's important to realize here, and I've got a note with respect to how it interplays with our permanent certification program. One thing is that we're not starting from scratch anymore, and a lot of the the growing pains, the learning curve that everyone had to experience with getting Meaningful Use Stage 1 off the ground had to do with really starting from scratch with the certification criteria from a regulatory perspective. This time around, we've got a body of certification criteria to work with, the 2011 edition, and through recommendations from the 850 Standards Committee and our own analysis, we've been able to carry forward roughly, and I've rounded up a little bit, 40% of the 2011 edition certification criteria to be unchanged in the as they're adopted into the 2014 edition. And so this means for EHR technology developers that these certification criteria are candidates are eligible for what we call gap certification. And that's really, when it comes down to certification, a gap analysis and a delta type of certification that we hope will provide additional efficiencies and expediency in certifications going forward, so that prior test results on any of these unchanged certification criteria could be used and carried forward and count towards 2014 edition certification. And so this is an area where we think we'll be able to provide some efficiencies that we weren't able to provide the first time around. Next slide. So I'm on slide 15, talking about redefining certified EHR technology. This is one of the, I like to say, the crown jewel proposals that we've included in our rule. One thing to mention is that, as folks experience, and I articulate in most of my presentations, so I'm glad I just remembered to stop at this point. We refer to certified EHR technology as a proper noun. So it's capitalized, capital C, certified EHR, capital T technology. And it's a regulatory term of art that's defined in our rule. And that's in order to make a clear distinction between EHR technology that's used to demonstrate meaningful use and meets the definition of certified EHR technology as we defined it, compared to and distinguished from EHR technology that's certified, and that would be lowercase c certified. So rarely, if ever, and we've tried to avoid this, to say something is lowercase c certified EHR technology, so as not to confuse folks between what it takes to meet the regulatory definition and EHR technology that's generally just been certified but doesn't meet the definition. On to the definition itself, our proper noun definition. The one thing that we've heard more than anything else since the final rules came out, and that folks have asked is why can't I have the EHR technology that I need to meet meaningful use and pursue my own pathway with the quantity of EHR technology that I'd like to use to meet meaningful use. And we listened, we've been listening, we took that to heart, and we took a hard look at what we could do to add additional flexibility and reduce regulatory burden in this case. And to give you a contrast of how our proposals, or how our policy exists today compared to what we're proposing, I'm going to walk through a couple other slides. And so the one thing, for those of you that have attested or that work for folks that attest, you'll know if you go to the Certified HCC products list, today as our definition and the policy related to certified EHR technology manifests itself, you need to get 100% on the Certified HCC products list, the chapel, in order to get that magical CMS EHR ID number to do your attestation. And so you need to have 100% of the certification criteria checked off for the setting in which you're seeking to attest. And this is regardless of the exclusions that a provider can qualify for with respect to meaningful use or the menu objectives that they've elected to defer. As our policy stands today, you need to have all of the EHR technology regardless of those circumstances. What we've proposed is a more dynamic definition that will allow for, in the outpatient ambulatory setting where there is a great variance in different scopes of practice. I'll move on to the next slide, please. So as an illustration of what it looks like today, and this is slide 16, we have a definition of certified EHR technology that I've referred to in the past as monolithic, right? We have a single circle, and that's representative of 100% in kind of pie chart wisdom of all the certification criteria that would need to be addressed by EHR technology in order for someone to have something that meets the definition of certified EHR technology. What we're proposing going forward for the EHR reporting period that would begin in calendar year or fiscal year 2014 is a more dynamic definition of certified EHR technology that reflects both that is driven by and informed by the stage of meaningful use that an eligible provider needs to meet or seeks to achieve, and takes into account the exclusions that they can qualify for, as well as the menu objectives and measures that they choose to meet to demonstrate meaningful use. Next slide. So at the center of this bullseye, and that's a term that I'm going to be using to describe that more dynamic illustration, is what we call a base EHR. And a base EHR is a concept that's rooted in statute. Congress gave us a definition that they called a quote-unquote qualified EHR, which included specific capacities. Next slide, please. So this table is an illustration of, on the left side, the first 5 rows are the statutory verbatim from the statute, the definition of a qualified EHR that we're referring to as a base. For communication reasons and for other ease of use and understandability, we chose to make a distinction from the statutory term to use this as a way to more easily communicate this new dynamic definition. So at the beginning of everyone's pathway towards meaningful use and meeting the definition of certified EHR technology as proposed, they would start with a base EHR. And that's something that we believe is fundamental for all providers, regardless of their scope of practice, regardless of the stage that they seek to achieve. And we've tried to identify, in accordance with the statutory definition, those certification criteria that would apply most directly. And so, there's one about the capacity to support physician order entry, and we have a computerized provider order entry certification criteria. And I'd note that we didn't try to cram in additional things into the base EHR because there are instances where there are particular exclusions in the meaningful use core that certain eligible professionals could legitimately meet. And if we included it in a base EHR, then we run into the same situation that we would be in today, where in order to meet the definition of certified EHR technology, they'd essentially be required to have more EHR technology than they would necessarily need to achieve meaningful use. So we tried to keep this set of certification criteria at a minimum. The one thing that we did add to the base EHR, which is fundamental, as everyone would say, has to do with the capacity to protect confidentiality, integrity, and availability, and really focus on privacy and security. And so we have a set of 8 privacy and security certification criteria for providers to make sure that their EHR technology has those capabilities. And in order to frame the policy outcome that we want to achieve, we've included these certification criteria in the base EHR so that it's really a fundamental concept for everyone to certify EHR technology. Next slide, please. So this is another illustration of how the 2014 edition certified EHR technology definition as proposed works out and kind of plays out with respect to being driven by meaningful use and the stage of meaningful use that a provider seeks to achieve. Going forward, if anyone asks me, how do I know if I've met the definition of certified EHR technology starting in 2014? I'm going to say it's as easy as 1, 2, 3 plus C. And that's because, as you can see on this concentric circle diagram, I'm on slide 19. At the center, again, of the bullseye is the base EHR. Here, regardless of the stage of meaningful use, the type of eligible provider that you are, you've got to have EHR technology with the capabilities certified to meet the definition of base EHR. And that can be done a number of different ways using, it doesn't need to be some product, it doesn't need to be some new thing called a base EHR. I did want to emphasize here again from that the base EHR is another definitional construct. So to meet the definition, it's a matter of having EHR technology that's been certified to those certification criteria that were in the prior table I've referenced. We're not advocating for this new label to be applied to EHR technology that may include those criteria, but we do request public comment on that concept. Moving out to the second and third rings of the bullseye here, that's where things really start to diverge, and that's where the flexibility is introduced with respect to the proposed definition of certified EHR technology. So if you're an eligible professional and you can meet an exclusion that is in the core objectives and measures for either stage 1 or stage 2, you wouldn't necessarily need to have EHR technology that's been certified to a 2014 edition, to the associated 2014 edition certification criterion, nor would your EHR technology developer need to go through the additional burden to get certified to that either. And so that's really where the regulatory flexibility and burden reduction that we've introduced to this proposal benefits both sides. So from the vendor's perspective, the EHR technology developer perspective, they don't need to go up front and build in those capabilities. I'll pick on, I have two examples that I typically pick on. One being with respect to chiropractors, who my understanding are not authorized to prescribe in many states, if not all. And today, as our policy, as our definition of certified EHR technology works out, if there's a particular chiropractic vendor that seeks to supply chiropractors with certified EHR technology, they need to include the e-prescribing capability. Well, those chiropractors can exclude that legitimately under meaningful use, but the way that the definition was constructed, they would still need to possess that capability of their EHR technology, and their vendor would need to build it in to get certified. So what we've done here is to try to release that that concept and that policy from both the vendor side and the provider side. As you move out to the menu ring, the third ring, that's really where there's a tremendous amount of flexibility and where the market, we hope, will be able to respond with an additional variety of combinations of different capabilities. And so for those eligible providers that seek to choose their own path one way in meeting the menu, they just need to make sure that they have EHR technology that's been certified to 2014 edition certification criteria to support those objectives and measures that they seek to achieve. Under the proposal, they'd no longer need to necessarily have, if they didn't feel it relevant, to have those EHR technology capabilities for which certification is required for those menu objectives that they wouldn't seek to meet for a particular EHR reporting period. It could be that in the first year of a reporting period, say for stage 1, that a provider chooses a certain set of measures, but then in the second year they choose a different set of menu measures, and for which they'd need to make sure that they still have 2014 edition certified EHR technology. So moving forward, this is a comprehensive slide. They're actually available on our website for each stage and type of eligible provider. So this is an example, an illustration of eligible hospitals, critical access hospitals seeking to achieve meaningful use stage 2 as proposed relative to the definition of certified EHR technology and the certification criteria that are applicable to each of those rings in supporting meaningful use. There are 4 of them available on our website. There's a link at the end of my slide deck that will get you there. Next slide, please. So with the proposal that we've made, it opens the door for a third way to meet the definition of certified EHR technology. Today, in order to meet the definition, again, this 100% certification criteria, a provider can either adopt a certified complete EHR, which by definition has been certified to 100% of the applicable certification criteria, or have an equivalent combination of certified EHR modules that also meets 100% of the certification criteria through the combination. With the proposed revised definition that we've got in our rule, it also makes it possible now for a single EHR module that's been certified to the 2014 edition certification criteria to have those capabilities that meet the definition of a base EHR that can satisfy and support a provider's ability to meet the meaningful use core objectives that they need to meet for the stage of meaningful use that they seek to achieve, and only those menu objectives that are really relevant to their scope of practice or that they seek to meet. And so you could envision a new set of I jokingly call them mega EHR modules that do way more than a little EHR module that can be certified, but a little bit less than a complete EHR, which really provides ultimate assurance that you've got all the capabilities that you would ever need to meet any type of meaningful use objective and measure. Next slide, please. So this is another illustration of how the definition that we proposed for the 2014 edition relates to the EHR reporting periods, as it also accounts for the proposed extension of meaningful use stage 1 for another year through fiscal year calendar year 2013. One thing I want to highlight for everyone that has a 2011 edition EHR technology that meets the definition of certified EHR technology, it is good all the way through fiscal year calendar year 2013. We did, in recognition that 2013 would be a transition year between those moving to stage 2 and moving to the 2014 edition certification criteria, included a revision to our current definition of certified EHR technology that runs through 2011 through 2013, that in instances where there's an equivalent 2014 edition certification criterion, there could be upgrades that from the 2011 edition that wouldn't invalidate, it wouldn't affect someone's ability to meet the definition of certified EHR technology. The one thing that I would mention here, and is noted at the bottom of these slides, looking forward to 2014, and this is another instance where we're trying to keep things simple, we're trying to keep things clear, we're trying to keep the message tight about what it takes to demonstrate meaningful use with respect to EHR technology. For the calendar year, fiscal year 2014, eligible provider will need to know two things: that the EHR technology that they have is 2014 edition certified, and that the 2014 edition EHR technology that they have that's been certified can support their achievement of the meaningful use stage that they seek to meet. And so that's that kind of correlation between the certification criteria and the meaningful use objectives and measures. The one thing also that I'll note is that in this initial rulemaking cycle that we had previously, there was one rule on stage 1, meaningful use, and there was one rule on certification criteria. But as we go forward, and especially keeping in mind future stages of meaningful use, we want to make sure that we aren't introducing additional confusion. And so from what we've tried to do from a clarity perspective is to try and make sure that there's only really one thing to remember, and that's your EHR technology has been certified to the 2014 edition certification criteria. And what that means, and I know it's been convenient for a lot of us, and I've found myself doing this as well, today you can get away with saying something is stage 1, meaningful use stage 1 certified. But that's not really a concept that we'd like to perpetuate, and I'd really like to ask for your help as you engage in conversations with others to make sure that you don't use or propagate that type of terminology going forward. The real core concept here is that going forward, we always want to make sure that there is one edition of certification criteria that supports all stages of meaningful use. And that's really the fundamental concept here in that box to the right that says MU stage 1 or MU stage 2. The difference here and the efficiencies and flexibilities that different eligible providers will have based on the stage of meaningful use that they seek to achieve is really the quantity of 2014 edition EHR technology that they'll need to have. It's really important from an interoperability perspective for making progress in the capabilities and functionality of EHR technology that the EHR technology that folks have once we put out a new edition of certification criteria are updated to meet that. So bottom line, starting in the fiscal year calendar year 2014 reporting periods, everyone will need to be on 2014 edition EHR technology regardless of the stage that they seek to achieve. I'm going to go through the next few slides pretty quickly. So you can hit next slide. This just says standards, standards, standards. And that would be my montage of in the movie world of a very quick montage of standards. This one I'm going to leave as a takeaway. Aggregated it down from a prior presentation into this one handy-dandy slide. This is kind of appending the 2014 edition changes to standards, implementation, specifications that we've referenced, some of the other ones that we've included. It isn't all-inclusive, just as a warning if anyone cribs the slide from our website. These are the ones that have to do most directly with the 2014 edition. Next slide, please. One other thing that I'll note for those of you that are read through and that are really focused on clinical quality measures, we devoted a good deal of our preamble to discuss clinical quality measures and their relationship to EHR technology and how we wanted to make it more rigorous, more EHR ready, and we focus on the CQM life cycle in our preamble of our proposed rule, as well as some of the identified challenges, and really seek your all's input, collective input on the path forward that we can seek to achieve to meet some of the goals that we have. Next slide, please. So we have a temporary certification program that is up and running and churning out certifications today. We have a permanent certification program that we established through regulation and that is undergoing establishment as we speak. And we expect that, as we note in our rulemaking, that the permanent certification program changeover and the sunset of the temporary certification program would occur upon the effective date of a final rule for the 2014 edition certification criteria. And in essence, in not needing this nomenclature between temporary and permanent, we had proposed to change the name. Yes, you do need to propose such things because they change the regulatory text. And then we've made some other revisions to reduce regulatory burden and add flexibility in our certification criteria and the certification processes. The one thing that I'll stop and talk about briefly here has to do with a certification criterion that we've included, which is new, related to safety-enhanced design. In November 2011, the Institute of Medicine at ONC's request had published a report on patient safety and health IT. And this is our first foray into addressing some of those recommendations. And what we did here, and I can't do it justice, but it's quite explained in detail in our preamble, is to set a first bar around safety-enhanced design. And this is the application of user-centered design processes, human factors analysis, etc., around the certification criteria that we believe pose the greatest risk to patient harm or patient care, and but also the greatest opportunity to reduce medical errors and to make patient care safer. And so in that respect, we focused on 8 medication-related certification criteria. Next slide. Some useful information. We're trying to enhance your public comment experience. If you go to the website, which is on the next slide, there's a Word version of our proposed rule posted. You can copy and paste from it to your heart's content. We've got a comment template up there, which we hope will organize and help you focus your comments, and it includes a bunch of information. I have a sample of the comment template next. We've also got another suite of kind of useful grids, the bullseye, more detailed illustrations, and some other materials. We have 3 ways to public comment. I'd recommend, and we prefer, that you deliver them through regulations.gov. You'll get a tracking number. You'll be able to follow up on your comment. It'll be posted once you get into our back end and click post. That's the most expeditious and easiest way to comment, so I would encourage you to do that. Next slide, please. So this is slide 28 on public comment template. The document's up now. This is generally what each of these little tables look like. So to ground folks, it has the title of the certification criterion, the meaningful use objective that it correlates with, and then the actual certification criterion language, the page range references for the tri-column Federal Register version, official version of the proposed rule. And then if we include specific questions in the preamble, we note that for everyone so that you can dig into that preamble and see if you can answer some of those questions that we had. And those are really important. And the one last thing I'll stress with respect to comments in general, please let us know the things that you have for which you've got constructive criticism and that you think we can do better. That's an area where always appreciate your input. And the other area which may go without saying, but I can't emphasize enough, if there are areas where you think we got it right or you think we got it really close to being right, let us know, and please let us know that you support the proposal that we've made. We do look through the comments, each one that we get, and look at the balance, and it's important for us to see that we've struck the right tone in some cases. In other cases, if there aren't any supportive comments, and it's hard for us to tell if everyone hates it, everyone loves it but didn't tell us, and that's an area where we're not mind readers, and it's really helpful to have your support as well as your constructive criticism. So please keep that in mind as you formulate your comments as well. And I think that will wrap it up for me. Thank you very much.
All right, Steve, thank you so much. You really covered a lot of ground quickly. We do have a lot of questions, so I'm just going to roll right into the questions. First of all, we have a question: where can we find the information for CFR 45170.314? Apparently that was not available on the gpoaccess.gov site.
So proposed rule, maybe this will be a little bit too regulatory speak, but so proposed rules don't get officially entered into the Code of Federal Regulations. It's only when a final rule is issued upon its effective date do they actually get entered into the actual Code of Federal Regulations through the GPO website. So the best you can do is to look at the proposed rule, and at the end of that is the actual regulation text that would be included at the point in time when we finalize it. So that's the opportunity and visibility into what the actual regulatory text would look like.
And will testing bodies be in place, or will certification be formatted the same as Stage 1?
Sure. So that's a great question. The permanent certification program has a slightly different architecture to it. For those that remember or caught prior presentations, in the permanent certification program, there are separate accreditations for different competencies with respect to testing and with respect to certification. There are two different accreditors that are responsible for assessing those competencies. Our colleagues at NIST run the National Voluntary Laboratory Accreditation Program, NAVLAP, which has a health IT line of business, and they will be accrediting competencies related to testing. And there is ANSI, who is the ONC-approved accreditor, who will be assessing certification bodies' competencies with respect to certification. And with respect to how the flow goes, put very simply, an EHR technology developer would go and get their test results with respect to how they relate to the certification criteria, take those test results from an accredited testing lab, bring them over to the certification body who would independently analyze them and determine whether or not to issue a certification in accordance with some of the other provisions that we have in our rulemaking. That doesn't preclude certain entities from being both a NAVLAP accredited testing laboratory and a ANSI accredited and an ONC and subsequently ONC authorized certification body from being the same entity. They do need, in accordance with those accreditations, to have certain firewalls and impartiality in place, and that's the certification program.
And Steve, how will module certification be different for 2014?
Great question. So the one specific difference, there's a couple other ones that aren't as big. The one specific difference that we dealt with from kind of two angles has to do with our proposal in the base EHR definition. So for those that remember the presentation that I just ran through, we included privacy and security now as a policy outcome in the definition of a base EHR. So at the end of the day, an eligible provider needs to have EHR technology that has been certified to those certification criteria in order to be on their way to meeting the definition of a base EHR. And by doing that, we were able to take a second look at our current EHR module policy that requires EHR modules. So today, if Steve's EHR module got brought in and I presented it to a certification body, I would need to show that my EHR module includes and can be certified to the privacy and security certification criteria that are in the 2011 edition. And there are some exemptions and exceptions that I could bring forward to justify why my EHR module shouldn't need to meet some of them. But through feedback that we received, this largely had been applied and was seen as without a tremendous amount of benefit, because on the other end, for providers that were adopting these EHR modules, they were getting, in some cases, disparate security functionality, and some EHR technology module developers were just simply building in the privacy and security capabilities just to get certified because it was easier than doing some of the documentation requirements. So what we sought to do here is to make it EHR module certification a little bit more pure with respect to, if you bring in a module to do X, you can get that module certified just for X. And that's a real clear difference with respect to EHR module certification. The other ones have to do with including some additional help and analytics from EHR modules to help eligible providers keep track of their utilization for meaningful use. And we took another kind of studied look at what EHR modules are capable of doing relative to the numerators and denominators. And so we require that any EHR module we propose, that any EHR module that's presented for certification would need to be able to, at a minimum, track the numerator for those measures, for those measures that it includes certification criteria to support. And that's a difference between the 2011 and 2014 as well. There's more, but I don't want to put people to sleep.
All right, Steve, so any idea, I don't know if you can answer this one, but do you have any idea when the certification criteria will be published and when the certification window will open up?
Another great question. So at best, timing-wise, we're trying to follow the same process that we took 2 years ago with the rulemaking cycle. So expectation, anticipation, goal, whatever other adjective I can put in front is to get the final rules published this summer as soon as possible. I think we all feel the same sense of urgency that you do. The rules will have typically the ONC rule, which is under a slightly different statutory paradigm than CMS, could have a 30-day. It will have a 30-day delayed effective date. That's again when the stuff actually gets entered into the Code of Federal Regulations. And so really, depending on when the final rules get published, I would say though, I'll be an optimistic more than half full, glasses half full guy. It would be great if the window for 2014 edition certification would be up and running in the late fall or early winter, before definitely before the turn of the year. That would be my goal and what I would be shooting for.
How does the 2011 edition versus the 2014 edition of certification criteria relate to temporary versus permanent certification for EMR software?
Another good question. So there's really not a relationship between the certification criteria and the programs themselves. because going forward, there will be overlap between when and this is a much longer conversation about validity, is a snapshot in time. And what we've said is that at the point in time when the Secretary adopts a new edition of certification criteria, a new set of certification criteria, then EHR technology going forward would need to be certified to meet that new edition of certification criteria in order to continue to be used to meet the definition of certified EHR technology. So the 2011 edition certification criteria it could very well be used by certification bodies in the permanent certification program for the period of time between, say the fall of 2012 and, through its useful life through 2013, at which point, 2014 edition certification would really be the, I think, the prevailing certification that would take off. And that's another reason why and I touched on this briefly, we've tried to add in some flexibility up front that eligible providers could get EHR technology upgrades for EHR technology that's been certified to the 2014 edition, for which there is an equivalent 2011 edition certification criterion. And as a public service announcement, there's an equivalency table that maps between the 2011 edition and 2014 edition certification criteria, both in our proposed rule and on our website as well to help folks make that crosswalk.
Steve, will the certification criteria be applied to cloud-based EHR systems?
Good question, too. We don't make a distinction between the type or I'm trying to think of the right type of framing to label cloud, but we don't make a distinction between how or which or why the EHR technology is implemented or provided to or supplied to an EHR, an eligible provider. So if the EHR technology can meet the certification criterion, then it can be certified, and we don't make a distinction between the types of implementations or applications that could be available to different providers.
And do you anticipate that the certification process will become more rigorous? The comment is also that many vendors were certified with the capability for certification, but actual deliverables in the field were missing around meaningful use capabilities. So will the certification get more rigorous?
Yeah, I mean, our goal and our vision is that certification will be more rigorous, and that's why we are eager to transition to the permanent certification program, where there's really these two stops of first you get tested, then you get certified, and it could be done by two different bodies. We think that'll add some rigor. Currently going through discussions with our colleagues at NIST about how we can introduce additional clarity into the testing procedures as well that they've developed, as well as just additional rigor overall. I think if folks have had challenges with things that come on delivery, best obviously to work with your EHR technology developer first, but you can also contact the certification body that certified the EHR technology. They have processes in place to hear about complaints, as well as contacting ONC. And in some cases, we don't have the resource to go out and follow every lead, but in some cases, we do try to get down into the weeds and figure out what's going on in case there are instances where our help could be or our assistance could be useful.
We're almost out of time. We're going to maybe try to do one or two more questions since we started a little bit late. So, Steve, can an EHR be certified if it does not meet all certification criteria of a base EHR? And if so, how would that be classified on the ONC website?
Great question. Glad somebody asked it. So it's important, and I'll try to emphasize this a little bit more clearly now. The base EHR concept is a definition. And so if you look through it, you can almost look at it like a checklist from the provider's perspective. So I'll make sure that everyone's kind of looking at it through the right lens. As a provider, if I look through the base EHR definition, and most likely, the table that we've put down right there, I don't remember how many certification criteria there are, but let's say for argument's sake, there are 15 certification criteria that are assigned to the definition of a base EHR. If you have EHR technology that has been certified to those 15 certification criteria, then the definition of base EHR would be met. It doesn't need to be its own standalone type of concept is one thing that I would try to articulate. So to the question, how the world gets divided, if something meets all of the certification criteria, then de facto it's a complete EHR. If something meets all certification criteria minus 1 or minus X, we classify it as an EHR module. So, stated another way, an EHR module is EHR technology that can meet at least one certification criterion that's been adopted by the Secretary. So, to the direct point of the question, if someone got EHR technology certified to meet half of the certification criteria that are assigned to the definition of a base EHR, it would be classified as an EHR module and representative of those 7 capabilities.
So one last question, Steve. For a hospital that will be on stage 1, year 2 during fiscal year 2013, but will have to implement functionalities for stage 2 during the same time frame, do you have any guidance on how to approach parallel functional reports for the measures on the same system?
That is a great question. You saved the toughest one for last, I'm sure. That's one where I would encourage the commenter or any of their colleagues that are listening to include in their comments to CMS in addition to ONC. A lot of those kind of feet on the ground type of comments. That's one I would bucket in terms of really knowing how you're going to need to adjust your approach to meeting meaningful use. I think there are some things that we will have to think about with respect to certification and how that's approached. I know that I've gotten some inquiries from EHR technology developers about how to handle that as well. So the best thing to do, and my guidance would be, in your comments, please, 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 include a specific scenario that really exemplifies the type of quandary that you're seeing right now or that you're thinking about, because those examples really help us put things into context when we go back into the department and have our kind of policy deliberations in drafting the final rule. And the more detail that we have and the more scenarios that you all have produced from your experience in the field, the better able we are to address your concerns.
All right, Steve. Well, we're going to have to let that be the last word. Thank you so much. You did a wonderful job, very, very informative presentation and Q&A, so thank you, Steve. And thank you all for joining us today. We are going to just pop up a very quick survey on your screen, so just please take a moment and fill out the short survey. We do use your feedback to shape our program, so just take a moment. And we hope you all will join us on Monday for the release of our new report on the Health Information Exchange Roadmap. So thank you all again, and have a great day.